You are listening to the 5-Second Rule podcast presented by APIC, the Association for Professionals in Infection Control and Epidemiology. This podcast is produced by the APIC Communications Committee and is intended to be a conversation between our hosts and professionals practicing in the infection prevention and control industry. You will learn and be entertained, but most of all, we hope you will be inspired by our community and the work of our peers. And now, on to the show.
Welcome to the 5-Second Rule podcast. I am Lerenza Howard, and my preferred pronouns are she, her.
And I'm Kelly Holmes, and my preferred pronouns are also she, her.
Today, we have a phenomenal guest with us. Dr. Matt Shoemaker graduated from the University of Health Sciences College of Osteopathic Medicine in Kansas City, Missouri in 2000. Dr. Shoemaker is certified by the American Board of Internal Medicine in Infectious Diseases and Internal Medicine. He was in private practice in Southeast Missouri from 2006 until 2019. He also served as Vice President and Chief Medical Officer at Southeast Health in Cape Girardeau, Missouri from 2014 until 2019. In 2018, he was advanced to a Fellow of the Infectious Disease Society of America. In July of 2019, he joined the University of Kansas Medical Center Division of Infectious Diseases as Assistant Professor of Clinical Medicine. He is currently an Associate Professor of Clinical Medicine and serves as the Director of the Division of Infectious Diseases at the University of Kansas Medical Center. Dr. Shoemaker, welcome to the show.
Thanks for having me.
Hi, Dr. Shoemaker. Yeah, we are excited to have you with us. So Dr. Shoemaker joins us for a special episode. There has been an increase in tuberculosis cases in Kansas City. And so Dr. Shoemaker is an expert and has joined us to talk a little bit more about this. So Dr. Shoemaker, could you, for the listeners, could you just tell us a little bit about tuberculosis, how it's spread, and, how infectious it is?
Yeah, happy to. Tuberculosis has been with us for a long time. There is some evidence that it's been around infecting humans for 20,000 years. There is evidence of spinal tuberculosis in Stone Age bodies that have been recovered. Prior to the industrial era, it was kind of a sporadic disease. But in Europe in the 17th and 18th century, with the Industrial Revolution, people were moving to cities, they were living in crowded tenements, and we saw an explosion of tuberculosis. In the 17th and 18th century, about a quarter of European deaths were attributed to tuberculosis. One would say, oh, hey, we've advanced so far, this isn't a problem anymore. TB is the leading infectious cause of death worldwide. For a couple of years, we got kicked down, that we had this thing called COVID, but now we're back number one. TB is predominantly a respiratory illness. It's spread by aerosol droplets. When people speak, cough, breathe heavily, singing's a big one, particularly people who have laryngeal tuberculosis, they can really spread it. Everybody worries about it. It is infectious, right? I guess not everybody worries about it. I worry about it, but I'm an infectious disease guy, so that's probably not a good example. It's spread by respiratory droplets, but you do have to be exposed for quite some time. Typically, we think of a heavy exposure being 8 hours a day on repeated exposures to somebody who's infectious. If you remember back to COVID, we talked a lot about the R naught. Like if one person's infected, how many people could they potentially infect? COVID's R naught is 2.5. Influenza's is 1. TB's is 0.7 to 1. So, and then if there's a measles outbreak in Texas, measles R naught is 12 to 18. So for every person with measles, we expect 12 to 18 people to get infected. For TB, it's less than 1. Yeah, that's the main thing. I always say, if you watch the movie Tombstone, the character Doc Holliday, played by Val Kilmer, he had pulmonary tuberculosis. He was wasting away and always coughing and coughing up blood.
Yes, yes. And, I think, our listeners are primarily infection preventionists, so they kind of have this background knowledge. But I feel like that gauge that you just gave us with the R naught is so incredibly helpful. And I do think that most of the population really don't know that much about tuberculosis and how it spread. So thank you for that.
If you pass somebody in the grocery store who has active tuberculosis and you just pass them in an aisle, I mean, your risk is essentially zero.
Mm-hmm.
Yes, that is
Now,
very
if
helpful.
if you live in a house with them, or say you work in a factory and stand next to them for 8 hours a day, your risk is pretty high.
Yeah.
And you can't get it from touching, kissing, hugging, nothing like that.
Thank you for shedding light on that, Dr. Shoemaker. I'm pretty sure that many of us as IPs join you in your sentiments of being worried about TB. I mean, it's never a good feeling to see that you have a potential case of ruled out TB and say, for example, the patient isn't appropriately isolated and maybe having the experiences of working up those TB exposures when the patient subsequently, the culture results are positive. But the focus of our conversation that I want to shift to is definitely what's going on in the current times in Kansas. So, in the latest news, as we see among many other infectious disease processes that are being reported in the news, we know that in Kansas currently there are 67 communicable active cases of TB in Kansas, and with 79 of the less serious latent cases of TB currently. So, with that, Dr. Shoemaker, can you provide an overview on tuberculosis outbreak in Kansas City area?
The outbreak started in a close knit community. The thought is that somebody probably had latent TB infection or dormant TB. We've kind of changed the terminology of it, that went untreated. And if you have latent TB, your risk of developing reactivation TB and becoming contagious is about 10% over the course of your life. If you have an underlying disease like diabetes, your risk goes up. So, probably somebody had latent TB, was never treated, became infectious, and tight-knit community, multi-generation households, people working in close settings, in factories and on lines, church events, going to school, all these things, once it started, even though the R naught's low, if your exposure is really high, say you live in the same house and you're with somebody 8 to 12 hours a day, then your likelihood of it becoming infected is higher. So that's kind of how things started. And then once it was identified, then we start doing contact tracing. We identify the people that have TB disease or active TB, identify them and treat them, and then try to find out who they've been in contact with so that we can evaluate them and determine what their risk is. Do they have active TB? Do they have latent TB infection? Or are they somebody that's just been exposed and we need to watch?
Dr. Shoemaker, when did the first cases come to light in this outbreak?
Spring of 2024.
Okay.
So, I mean, go ahead.
No, I was just going to ask, so with it being spring 2024, what really precipitated it now becoming, seemingly now becoming now becoming the focus of public attention nationwide?
I'm not really sure why now. I mean, we've been working on this for, almost a year. I became involved in late July, early August of 2024. So why it became a national issue now when our epi curves are improving, I'm not really sure. I'm glad it did come to light, particularly with what's happening with public health across the nation. Hopefully this will, keep people's minds on this at the forefront and continue to support public health.
We know the typical clinical symptoms of tuberculosis. Were these cases the typical presentation, Dr. Shoemaker? What have been, some of the most common symptoms among the cases that have been identified? And then what efforts have been made to educate the public around, transmission, symptoms, treatment options?
Yeah, no, good. That's excellent. The symptoms are respiratory, cough, sometimes a productive cough with discolored sputum. In some cases, we'll see hemoptysis, fever, weight loss, anorexia. Those are kind of the big ones. For people with pulmonary TB, we have seen a few cases of TB presenting as a pleural effusion. So those patients would have chest pain, maybe shortness of breath, depending on how big the effusion is.
Yeah, those are very non-specific kind of symptoms. Someone comes in with the fever and not feeling good, hasn't been wanting to eat in a while. It could be pneumonia. It could be, a lot of different things. So is it really, getting the patient in for the chest x-ray to really confirm the diagnosis?
Yeah, I mean, no, I mean, it's the end of February here while we're recording this. And so somebody comes in with a fever and body aches and a cough, it's influenza until proven otherwise, right?
Mm-hmm.
And then we start thinking about COVID and you just start going down the list, and TB is lower on the list. So it does make it harder for diagnosis, especially if the evaluation is being done by somebody that doesn't have this at the front of their mind, on their differential diagnosis. So yes, getting them in and getting a good chest x-ray is paramount. We also like to get sputums, send those sputums off. We like to get one a day for 3 consecutive days, if possible, early morning, because at night, you're not coughing as much. So sputum will kind of collect and you'll have a better sample. We did a lot of sputum inductions with hypertonic saline. It really helped to get some people to really get down there and get some good samples. And then we send that to the lab and we do the acid fast bacilli or AFB smears,
Mm-hmm.
as well as cultures. And then we started doing 2 molecular tests on the sputums. On 2 different sputum samples, we do a PCR as well, even if it was smear negative.
Oh, wow.
Are you
Yeah.
finding, like the higher AFB counts in these patients? Usually when we see the AFB come back with like 3+ AFBs, we're like, okay, this person is probably highly infectious. But then, like you said, you can get the AFB negative, which can delay diagnosis. It can, but we typically think of those people as maybe not quite as infectious as the 3+ AFBs. Is that accurate?
Oh, absolutely.
Okay.
Yeah.
Mm-hmm.
The higher the AFB count, when we go 0 to 4+, the higher the count, the more infectious they are because they're coughing up more bacilli. So there were some people who were smear negative, but they had an exposure and symptoms in an x-ray, and we went ahead and started them on treatment. Some of those ended up having positive cultures and some had negative cultures, but we said, hey, we think this looks enough like it. We're going to call it a clinical case and treat them.
And I think that this is from experience IPs, but definitely for the newer IPs, because I know it was very scary, because not having this foundational information as far as the level of infectiousness, but subsequently learning in partnership with our local public health department, they were integral in providing, resources and educational material related to that. Also, it's integral to have those physician stakeholders and clinical teams that are engaged in these conversations, because as you noted, it's very important in these atypical cases, especially to have TB included within the differential diagnoses, as I'm pretty sure many cases of TB outbreaks or clusters have occurred because, that just wasn't on their minds as far as ruling that out. But I'm curious to note, in a time of tuberculosis and TB, having a TB outbreak, we know that as infection prevention community, how this can have implications on our vulnerable population. So Dr. Shoemaker, I'm curious to know from your purview, can you share any insights on the implications of this outbreak on the vulnerable population in Kansas area, but with susceptible to TB infections, including those with an immigrant status, those that are in prison or recently incarcerated, and the unhoused population?
Yeah. I mean, when we look at TB, not just in the United States, but worldwide, one of the most vulnerable groups are those people living with HIV. So they have a high risk of not only acquiring the infection if exposed, but then the infection developing active TB. So the most important thing for people living with HIV is to be screened for TB, but really getting them on good antiretroviral therapy and helping their immune system. Other significant at risk are children less than 5 years old. Children less than 5 years old are more likely to develop disseminated disease, including tuberculosis meningitis, which can be devastating. You mentioned congregate settings, high transmission rates in congregate settings, correctional facilities, homeless shelters. And then a lot of times those people have other risk factors. Illicit drug use, injection and non-injection puts you at higher risk. Malnutrition, as well as smoking and diabetes.
Yeah, Dr.
Yes.
Shoemaker, I'm curious to know, have you all, if you can share, have you all experienced any challenges in some, because I know, say for with our IP experience, sometimes it can be challenging if you have individuals that are moving frequently or those that are unhoused. So have you experienced any challenges as you all address the TB outbreak with having those that are, moving around or those that you can't actively monitor from a public health sense?
Yeah, so for currently, we really fortunately, have not had the problem of unhoused persons in this outbreak, but we have had the challenge of people moving. The way public health works is it's each county has their own public health department, and then each state has their own Department of Public Health. Uh, the University of Kansas, where I work, we sit in Kansas City, Kansas. We're right on the state line with Missouri. So some of these patients would move from county to county in Kansas. Some would cross over into Missouri, and it made it challenging to be able to find these folks and make sure they received appropriate care. Um, Community health workers that were native speakers for the group, and that was integral in not only communicating but gaining trust in the community that we were here to help.
Oh, that's very helpful. In other countries, people receive the BCG vaccine, where tuberculosis is very endemic and there are high rates of it. And we know that that vaccine is not 100% effective, and we don't give it in the United States. But it does bring up a lot of questions I've noticed, like in new hire orientation, or people will come and say, hey, I've had the BCG vaccine, can I get the skin test? Or, I've always had a positive skin test. Have you had any, cross reactivity with your BCGs? Has this population received that vaccine?
For this population had received the BCG. Those born in the United States and the community obviously did not. The BCG is given to infants in countries where there's a high incidence of TB, and the goal and what it does is it prevents disseminated disease in infants, particularly TB meningitis, which, like I said, can be devastating and has a pretty high mortality rate. The effectiveness of the BCG in preventing pulmonary TB in adults is negligible, and we don't even consider it when we're trying to test someone. There is some cross-reactivity with the BCG and the TST or the PPD. You can get around that if you use an IGRA, which is a blood test that looks at lymphocyte function.
Yes, that is very helpful. And then do you have any, false negatives with your IGRA tests or false positives, either way?
So false positives, I really haven't seen, because your pretest probability in these patients, at least in the outbreak setting, is high, right? So you're going to have fewer false positives. False negatives you can see, particularly in people who have low lymphocyte counts or dysfunctional lymphocytes. So somebody with advanced HIV, somebody who recently received chemotherapy that was targeted at lymphocytes, they could have a false negative. For our people living with HIV, we like to get them on meds and get their CD4 count over 200 before we do the test.
Okay. And I had a question related to ferrin, and I'm bringing this up because in partnering with clinicians, some clinicians do not understand the premise behind or the purpose of a quantiferin testing. And, I find myself and others having to educate on what the quantiferin is testing for. So for those that may not understand, and because, of course, I've experienced pages or calls when they see the quantiferin testing being ordered, they're panicked. So for anyone that's listening that does not know what the quantiferin is testing, can you shed light on that and clarify this as it relates to TB?
Yeah, so the quantiferon or the interferon gamma release assay test, whether it's quantiferon or T-spot, looks at lymphocyte function to see if that lymphocyte has a memory of being exposed to tuberculosis proteins. It is interchangeable with the skin test, right? It's the same thing. So ordering an IGRA or a quantiferon is the same as ordering a TST. It's not going to tell you if they have active disease. It's only going to tell you that they've been exposed to tuberculosis and their lymphocytes were able to mount a response. So it's helpful in screening for exposures, but you have to do a number of other things to diagnose tuberculosis, right? The chest x-ray, the sputums, and all that. Currently, and I haven't seen this, where if you order an IGRA, the patient gets put into isolation. I haven't seen that. That would be problematic. I have seen if you order sputum AFPs, patients get put into airborne isolation, which I think is appropriate.
Well, you bring
Because if you're go ahead.
You bring up a fantastic point as infection preventionists. And then, what I have seen in the past is a patient will come in with these signs and symptoms that you described. And, they're thinking pneumonia. It might be an HIV positive patient with some very complicated things going on. And they're admitted to the hospital. And then 2 or 3 days later, tuberculosis becomes part of the differential diagnosis. And so then everyone is worried because this person has not been in the appropriate airborne isolation, and we have exposures to deal with among the healthcare staff, and everybody panics, that, oh no, I'm going to get TB. What do we do? What do we do? And so asking those questions, what is the magic question to ask to identify tuberculosis as soon as possible, or what should be the trigger of putting someone into airborne isolation? So you did mention the ordering of the AFB, which I agree with you, but do you have any other tips to help us address this challenge?
And that's a tough question, because as we talked about earlier, the presentation for tuberculosis is so ubiquitous. Fever, cough. I mean, it's respiratory viral season right now, right? So, you just have to be aware of your patient's exposures and their immune status, right? Have they had an exposure, and are they in one of those high-risk groups? People living with HIV are in that high-risk group. You don't really even think about the exposures because their risk is so high. So if they come in with something, with a respiratory illness, and they're coughing, they're having fever, and there's some abnormalities on the chest x-ray, particularly upper lobes, we get that should go up on your list. But TB, much like measles, that we're seeing in Texas, TB is not something that is seen very frequently in the United States, thankfully. So providers that may not have that on their differential to think about. So we just have to be cognizant of it,
Yes. So those respiratory screening questions that are asked in the ED or any point of entry for a patient who's being admitted, I think that we kind of get into, auto mode, and you just kind of, hit return, and move through those questions, but really educating those frontline staff on how important those questions are, why we're asking them, what we're looking for, and then doing that critical thinking step, beyond the symptoms and thinking about the population in which they live and other risk factors that can be involved. So that's good advice.
Yeah, I mean, I think a big one to just kind of keep on the list is country of origin. If somebody comes in with a cough, a fever, and pulmonary infiltrate, and they just moved here from a highly endemic area, it's different than if it's a farmer from the middle of Missouri that has not left his county in 50 years, right? So just kind of keeping that in the back of your mind as a screening question.
Yes, absolutely. That's very helpful.
And I think that there's also an area of opportunity to evaluate those respiratory questions that you're asking during the ED. For some organizations, maybe there's an opportunity to bolster and improve that process such that based on the scoring, there is that high alert of a potential case of TB. So to isolate appropriately while the patient is in the ED opposed to once they're admitted to the floors. In addition to our next topic, I would be remiss if I didn't discuss with you, Dr. Shoemaker, climate within our nation as it relates to public health, and what some can surmise is a divestment in public health. So I would really want to know your thoughts on what role does the United States play in the global fight, not only against TB, the focus of our conversation today, but of course we have currently in our news, we have the H5N1 avian bird flu cases that we're dealing with and the implications of that, including our grocery costs.
Yeah, I mean, I think historically this has been the case. I think the United States has been a leader in the fight against a lot of these pathogens, right? Even ones that may not be endemic here, like Ebola. We put a lot of resources and effort into that. I think we should continue to do that. I think the United States pulling out of the WHO, we will look back on it and see the gravity of the mistake. And you said divestment. I think divestment's right, but I think public health and science is openly attacked now. And this kind of started back in COVID, where people don't respect the facts. They just disregard the facts. And it's very challenging. So you've got a public perception of it, and then you've got the financial impacts of the government cutting these programs. I think we have some challenging days ahead of us for people who work in infectious diseases and public health.
Yes, very sombering to think about and challenging. I think social media with COVID especially, people are saying all kinds of things, and, being able to determine, what is fact and what is opinion, has been really confusing for the public at large. So really trying to build trust in our public health experts and having people listen to those right messages is key. As infection preventionists and infectious disease specialists and epidemiologists, I think we're tasked with getting that message out there the best way that we can. But I agree that, it will be interesting to see how this unfolds, and hopefully we will have the funding and support to nip these outbreaks in the bud.
Absolutely.
So despite these current challenges, Dr. Shoemaker, because it is kind of scary at this time, but what promising advancements or initiatives give you confidence in the future and in our public health infrastructure, thinking about like young professionals who are reading the news and perhaps still at university where funding is getting cut? What advice can we give to them about the impact that they can still make?
I think we have to continue to encourage those who may go into public health or infectious disease or infection prevention in some level, and let them know the importance of it and continue to have our support if they decide to go down that career path, right? It's tough. It's a tough sell right now with the political climate. But what we do is important, right? We keep people safe, and ultimately we save lives through our prevention efforts. One of the challenges is a lot of the efforts we do, whether it's a hospital infection prevention program or a public health effort, there's no revenue generated through that. So people don't see the impact. So we have to try to sell it in how much money we saved the hospital or the county or the state by preventing these infections. It's a little harder to grasp that impact.
Yes.
But it's real.
Yes.
Yeah.
Right. It's a real impact.
Building that business case.
Just look at hand hygiene, right? Like if you can, change your hand hygiene rates, and you can go back to your hospital administration and say, well, look how many cases of C. diff we prevented by these hand hygiene efforts.
Monetary value, because of course you have to speak the language of those individuals on how that is saving the organization money, but first and foremost it's protecting the patients and the hospital staff as well. So absolutely, what you and Kelly noted, in these times it does appear as though it really comes to us as a community, right? Infectious disease and infection prevention and control community, to really bolster our efforts and highlight the work that we do. I know APIC has done had some efforts in promoting and supporting the work that we do, but then not only that, speaking against the inappropriate, I would say, practice of harping our efforts related to addressing infectious diseases, both nationally and globally. But with that, it really places a level of we want ownership from our governing entities, and then also we have to also support and put that message out there on the importance of our professions and the work that we do, and counter counteract any misinformation that is out there on social media platforms. So with that, I know during the times of COVID, many, IP colleagues would note that there was maybe a gap in preparedness, emergency preparedness. So with this current case, I would love what lessons that you've learned or you and your colleagues have learned about this outbreak that could be applied to TB prevention and response efforts.
Yeah, no, that's an excellent question. I think one of the big things is identifying those people with latent tuberculosis infection and making sure they get treated, right? Because that's how the next outbreak's going to happen, right? Somebody has latent TB and they're out in the community and they have uncontrolled diabetes, or, they get Humira, one of these TNF blockers, and now they have active TB. So we have to identify these patients with latent TB and make sure they get treated so that they don't develop active TB and become contagious. So that would be like testing events, right? Identifying high-risk populations and getting them tested. Now, in the current times, high-risk populations would be people from countries that have an increased incidence of TB, and some of those people, they may not have legal immigration status, so it's hard for us to engage them, because they're worried about being deported, and we're just trying to make sure that we get them screened and treated for tuberculosis, right? So that's going to be a challenge. I think the current focus on illegal immigration is going to have some impacts on public health. Yeah, I think that's the big one. Identifying people with latent TB and getting them treated.
I agree, because they are like the if you have the iceberg, and the tip of the iceberg is what we know about in the active TB with the signs and symptoms, but all that surface area under the water is that latent TB, and they're spreading through the community, and of course we can't get tuberculosis from someone who has latent TB, but it can reactivate, and then these people are going undetected, so it is a major health concern.
And educating primary care providers on this, right? I mean, I have seen patients who said, oh, well, some provider told me I didn't need to get treated because my x-ray was okay. And I'm like, well, but you still have a 10% lifetime risk of having reactivation TB and becoming contagious.
Yes. And it's easier to treat the latent TB, right? It's one drug versus the 4 drugs.
We've gone away from the one drug, the isoniazid, for 9 months, and now we have multi-drug regimens that are 3 to 4 months.
Okay.
The one we use the most currently in public health is isoniazid and rifapentine once a week for 12 weeks under directly observed therapy.
Okay. Which is also difficult, right? Because somebody has to go every single day and make sure that this person is taking their meds appropriately.
Well, we've leveraged technology. We have a HIPAA secure app, so we have them do their video and take their meds, and then we review the videos at a later time. They send us the videos.
That is a great way to leverage technology, for sure.
Yeah, it's been very helpful. I mean, because you're right, we don't have the staffing to go to everybody's house,
right?
And they may not have transportation to come in, or it may interfere with school or work. So this video has been a very big help for us.
Now, has that been something that's part of the new outbreak kind of management, or have you been doing that for some time?
It's been available for some time. I think with this outbreak, we had a higher uptake of use. But yeah, it's been available.
Great.
Absolutely. And that's a great opportunity or a great reflection of really addressing the needs of the community, right? As you noted, there are many different aspects of that present barriers to care and adequate care. I'm pretty sure others have experience just with patients meeting the expectations of the direct observation therapy. So providing that virtual or telemedicine approach is absolutely integral.
That extends to people with active TB too. It wasn't just the latent TB cases where we were using video. We were doing it with people with active TB as well.
Yeah, for, health institutions to adopt that approach, right? To provide that effective mitigating strategies for that and other. Well, Dr. Shoemaker, it has truly been a pleasure to have you on this show to discuss timely topic. I thank you for sharing your knowledge and expertise with us, and I wish you well.
Yes,
Lerenza,
I echo.
Kelly, thank you.
Yeah, thank you so much, Dr. Shoemaker. It's been a pleasure. There's so much more work to be done. Thank you for highlighting all the work that you are currently doing, and we appreciate you. So thank you.
Thanks for listening to APIC's 5-Second Rule Show. We want to hear from you. Visit us at www.5secondruleshow.org. That's with the number 5, where you can contribute to the conversation. Make sure you subscribe and rate us wherever you listen to your podcasts. We're so appreciative of the hard work each of you do every day to make a safer world through infection prevention. Remember, IP stands for Important Person. You are awesome. Stay safe, and we'll see you next time.